Hi, my name is Tori Nakua. I am a nurse practitioner student, and today I will be performing a head to toe assessment on my patient. Is that okay with you?
Yes.
Okay. First, we're going to start off by assessing a few orientation questions. Can you please tell me your name and date of birth?
Jay Nakua, March 4th, 1991.
Okay. And can you tell me your age and ethnic background?
I am 34 years old, Asian.
And what state are you currently in?
I'm in Nevada.
And what is the current month?
February.
All right, thank you. Um, and then, and if any time you feel uncomfortable or pain, we can pause. Just let me know, okay?
Okay.
So I will start by explaining general survey of Jay. This is a Jay, 34-year-old male. He is healthy. Well, he's well developed. He is alert and oriented times 3. He is responsive to all questions. His color is uniformed throughout for his ethnicity. He is dressed appropriately for this occasion of doing my assessment today. He is well groomed. His posture is upright. He is in a relaxed position, and he doesn't seem like he's in any current distress. We will start with examining the head, face, and neck. I will start by inspecting his hair and scalp. His hair is evenly distributed, no alopecia noted. I'll palpate. Let me know if there's any tenderness. Any tenderness?
No.
Okay, no tenderness, no masses, lesions noted. His skull and scalp are normal cephalic and no trauma noted to the head. He said no tenderness. I didn't feel any drainage either. His facial features are symmetrical. His skin was warm to the touch, and his skin color is appropriate for his ethnic background. No visible redness, swelling, drainage noted. Next, we will palpate the frontal and maxillary sinuses. Let me know if you have any tenderness, okay? Any tenderness?
No.
Okay. Any tenderness?
No.
Okay. No tenderness of the facial or maxillary sinuses. Then we'll move on to doing the assessment of the eyes. So his eyes are, can you look at me please? His eyes are symmetrical as well as his eyebrows. I don't see any visible drainage or crusting of the eyelashes. His sclera is white. His cornea does not have any opacities in it. His lenses are flat. No swelling of the eye area. I'm going to look at the lower part. Okay. Conjunctiva is pink and moist. And the cornea, I talked about clear, no opacities. Okay. And then we'll go on to your vision test with the Snellen chart. I just have this one here. If you could just hold it out in front of you with your arm extended, then you'll cover your left. Let's do left first. Okay, you got it?
Yes.
Okay, and if you could please just read the lowest line you can.
HPFTL.
Okay, you did it backwards. It's okay. You did it backwards. It's okay. 20/20 vision. And then let's cover your right eye, and we'll read it forward facing the lowest line you can.
LTFPH.
Excellent. Okay, so good vision, 20/20 in both eyes. Do you use any corrective lenses?
No.
Okay, so without corrective lenses needed. The vision test, it assesses the cranial nerve 2, which is the optic nerve. This is a sensory nerve. Okay, and then we're going to look at the pupils and the eye movement, which we'll be assessing the cranial nerves 3, 4, and 6. And these have control over the eye movement and our motor and these are motor nerves. So cranial nerve 3, this is the ocular motor. It is responsible for pupillary constriction and it raises the eyelids. It also is responsible for, or raises the eyelids with the levator muscle. It also is responsible of using other muscles in the eye, such as the superior, medial, and inferior rectus. It's as well as the inferior oblique muscle. We have the cranial nerve 4, the trouncular nerve, which is responsible for the inferior medial movement using the superior oblique muscle. And cranial nerve 6. This one is the abducens, and it's used for the lateral eye movements and uses the lateral rectus muscle for the movement. Okay, and we will check pupillary restriction. I'll use my pen light. And if you can look straight, thank you. Look straight ahead for me. Okay, both left and right eye constrict to direct eye, direct light, and then we'll do indirect light. So we'll shine it into the left first, checking the right. Okay, we'll shine it into the right, checking the left. Okay, and they both reacted as well to indirect light, so consensual response is also intact. Excuse me. His pupils are a size, I would say about a size 4. Okay, and then we'll check accommodation. So look straight ahead. Okay, and then look at my finger now. Okay, so accommodation's intact. And patient has PERLA. Pupils are equal, reactive to light. Equal, round, reactive to light, and accommodation is intact. Perfect. Next, we'll be moving on to the extraocular movement of the 6 cardinal signs. So this one, you're just going to follow my finger, okay? So we'll start here. So his eye movements were smooth and full. I didn't see any nystagmus or paralysis of his eye muscles during the examination. Next, we'll assess the fundoscopic exam using the ophthalmoscope. If you can turn facing towards me, thank you. It might be a little uncomfortable. I have to get close to your face. Looking straight ahead. Red reflex is present in the right eye. Move closer. Okay, we'll check the left eye. Red reflex present in the left eye. Okay. Excellent. So the red reflex was present in both eyes. His optic disc was clear and it was creamy pinkish color, and it had sharp margins. Disc ratio was less than half, and no orbital edema was noted. Sorry, excuse me. His retinal background was red and orange, with the macula slightly darkened. His vessels, the arteries were bright red, veins were purplish, veins larger than the arteries with a 2-to-3 ratio. And no edema noted, no redness noted of the eyes, no drainage, no hemorrhaging was visible on assessment. We'll move on to his ears. Okay, upon inspection, if you could just look at me first. His ears are symmetrical. They're aligned with the, what is this? Aligned with the canthus of the eye. I'm going to palpate. Any tenderness or pain?
No.
Okay, no tenderness or pain, no masses, no lesions, no visible drainage noted. And then I'll go and do the mastoid process, which is the bony process behind the ear. I'm going to palpate that. Any tenderness or pain?
No.
Okay, we'll do the left side. Any tenderness or pain?
No.
Okay, and if there was, that would have meant that there was some kind of ear infection. And, what did I say? And then we'll be doing the tug test. So I'm just going to pull up and back on your ear and just let me know if there's any tenderness with that, okay?
Okay.
So we'll start with this ear.
No pain.
Okay, and then can you put your ear towards the camera? Okay, and then up and left.
No pain.
Okay, so right and left ear, there was no pain with the tug test. And then we'll go to, otoscope exam. Can you turn your head a little bit? Okay, up and back. Okay, I'll check the left side. Up and back. Okay. The external auditory canal was pink. Moderate earwax was noted. I forgot to mention this is the auricle of the ear that I was palpating. His tympanic membrane was a pearly gray. I didn't notice any redness, no lesions or anything in the ear. The cone of light on the right side was at 5 o'clock, and then the cone of light on the left side was 7 o'clock. And then the handle and short process was visible. Yeah. And then we'll move on to the nose inspection. Take a look at me. His nose is symmetrical. I'm going to push up a little bit. I'm going to look in the nose. Okay. So his NARS bilaterally, the mucosa was pink and moist. No lesions or ulcerations. I didn't see any bleeding or polyps. The superior tuberant is not visible on this examination, but the inferior and medial tuberant were visible. And then assess the first septal deviation. I didn't think I saw it, but yeah, no. Sorry. And no septal deviation noted. It was midline. I'll assess his lips, inspection. They're pink, they're moist, no dryness. Can you smile for me? Teeth are well aligned, good hygiene. I'll have you open. I'll use this thing. Sorry. Gums are pink and moist. No ulcerations or swelling, no bleeding noted in the gums. Teeth, he has missing teeth, but no dental caries noted. We'll do the roof of the mouth. Can I see the roof? Okay. And under the tongue. Okay. Pink and moist, no ulcerations, no, tongue, can you stick that out for me? Okay. His tongue is pink and moist. I didn't see any white patches, no lesions, no fissures on the tongue. And then I'll do this. I'm going to assess the buccal mucosa. Oh, you don't have to stick out your tongue. It's the size. Okay. Buccal mucosa as well as pink and moist. No ulcerations, no swelling, no bleeding. Next, I'll be inspecting the tonsils, oral pharynx, and I'll first explain the Malaparte airway classification. This is graded for 1 to 4, and it's used to show the amount of space available for intubation, or if someone is at risk for obstructive sleep disorder, apnea. So number 1 is that you can see the full soft palate, the uvula as well as the pillars. Number 2 is you can only see about halfway. And then number 3 is you only see the top part of the uvula. And number 4 is you only see the hard palate. So I'm going to first assess the tonsils. So if you can stick out your tongue as far as you can. Okay. So his tonsils are +2, so it's halfway, fills 50% of the pillars. I'll look at the uvula. Okay, relax your tongue. Relax. Okay, stick it out, but relax the tongue. Okay, so you can only see the top part of his uvula, but it was midline from what I saw. His soft palate was visible, and I would give this a grade of a 3 based off that scale for the oral pharynx. It was pink and moist and free of lesions or ulcerations. Okay. And then let me turn this off. We'll go to inspecting the neck. So if I can look at your neck. So his neck is symmetrical. No visual masses, no goiters noted. The skin is appropriate for this ethnicity. I do not see a jugular vein distension. And I'll palpate his trachea. I don't see any deviation of the trachea though. Yeah, his trachea is midline. And then I'm going to go behind. And then I'm going to assess the thyroid. 3 fingers, palpate. Any tenderness, pain when I palpate?
No.
Okay. And then I don't feel any masses or nodules. And then if you could look right down. Okay, we'll palpate that way. No masses or nodules. And we'll go left down. And then no masses or nodules here either. Okay. Okay, so we're good on there. And we're going to move on then to your lymph nodes. Okay. So lymph nodes, you have your preocular lymph node, postocular lymph node, occipital lymph node in the back, tonsillar lymph node, submandibular lymph node, submental lymph node. You have the anterior superior cervical lymph node, deep cervical lymph node, and then we have the supraclavicular lymph node and the inferior clavicular lymph node. Let me make sure I got all those. Okay. And then, so all his were small palm palpation. They were all soft, they were mobile. If they were abnormal, you would feel like fixed, enlarged lymph nodes and like tenderness to the site. Did you have any tenderness upon palpation?
No.
Okay, good. Thank you.
Thank you.
Performing hand hygiene. We're back, and I'm going to be assessing the posterior thoracic region of the chest area to allow for patient privacy. He's keeping his shirt on, but normally we would be assessing direct skin. So I will look at the posterior thoracic The shoulders are symmetrical. His scapula is symmetrical. The spinous process is straight. His skin is normal for ethnic background. No abnormal curvatures are noted. I'm going to compare the anterior posterior diameter. So you want a 1-to-2 ratio, which he has. So he does not have any barrel chest noted. He is relaxed and comfortable. He has easy respirations. They're unlabored and quiet. Now I'm going to palpate. Please let me know if you have any tenderness or pain.
Okay.
Okay. Any tenderness or pain there?
No pain.
Okay, so no pain upon palpation, no masses noted. Then we'll be doing respiratory expansion. So scapula's T8, so just gonna go a little bit lower. I'm gonna push in. Deep breath in for me. Great, and exhale. So his expansion is symmetrical. My fingers rose equally. Then we're gonna do tactile firmitis. So what I'm going to have you do is say 99, and I'm going to be assessing the vibrations. Okay?
99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, last one.
99.
Thank you. Vibrations are equal in bilateral lungs. There was no increase, decrease, or absence of vibrations in any lobe. We're going to do percussions over the lungs, and what you want to hear is resonance, which is the clear, low-pitched sounds for the lung, and then dullness would be, you would see consolidation, and then hyperresilience is like air-filled areas, and then over flat areas, or a flat sound is typically over a bone. So, percuss. Resonance noted in all lung fields bilaterally. And then we're going to check the CVA tenderness. So that's going to be in the 12th rib cage and assessing the kidneys. Just let me know if you have any pain or tenderness. Any pain or tenderness there?
No.
Okay. And then we're going to do some auscultation. So we have the bronchodilatory sounds, which is heard in the mid-scapular area, the vascular sounds, which is heard in the lung peripheral area, and then we have adventitious sounds that would be heard if there was any abnormal pathology, which is like wheezing, rales, rhonchi, stridor, diminished breath sounds. Okay. You're going to take a bigger breath than normal, deeper breath, every time you feel my stethoscope, okay? Sorry, give me 1 second. One more time. Thank you. Lungs are clear and equal bilaterally. Then we'll be doing the epiphysi. I'm going to listen and you're going to say the letter E. So if I hear a muffled E, that is fine. But if I hear like an A sound, that can mean like there's fluid or consolidation. Okay, and then every time I move, just say the letter E.
E, 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 E.
Thank you. Lungs clear upon auscultation bilaterally. And then we're going to turn around and assess the front side. Okay. Inspection, his chest is symmetrical. His shoulders are symmetrical as well. No pectus excavatum noted. And then the anterior posterior diameter is the same, the 1:2 ratio. Skin wise, there's no lesions noted. No scars or masses visible. And he has smooth, dry, warm to the smooth skin. And the color is appropriate for his ethnic background. Respiratory rate is regular, non-labored. His chest falls equally, and his breathing is quiet. And I do not notice any accessory muscles. So I'm going to do auscultation again. Make sure it's on my diaphragm. Take a deep breath again as my stethoscope moves. Very good. Last one. Thank you. Okay. And then with the breath sounds on the anterior side, the bronchial breath sounds are over the upper part of the respiratory tract, in the trachea area. The bronchovestibular is heard over the bronchi, and the vestibular is over the peripheral lung tissue. And then again, the adventitious sounds that you can hear: bronchi, wheezing, stridor, diminished breath sounds. And then we'll move on to the cardiovascular exam. So if you don't mind lying down for me in a supine position, 30 degrees. Okay. Make sure you're getting in the camera. Okay. So we'll begin with the inspection of the chest, pericardial area. No visual pulsations, heaves or lifts noted, equal rise and fall of the chest. And then I'm going to palpate the 5 pericardial areas. Before I do that, I'll explain what they are. We have the aortic at the second intercostal space on the right sternal border. Then you have the pulmonic on the second intercostal space on the left sternal border. Down you'll have the herbs point, the third intercostal space, left sternal border. Then you have the tricuspid, a fourth intercostal space on the left sternal border. You go over here and have the mitral at the fifth intercostal space at the midclavicular line. And first I'll be using my fingertips to assess for any heaves or lifts. So a little palpation. Going on over the 5 cardinal. No heaves or lifts noted. Then I'll use the ball of my hand to assess for thrills. And no thrills noted either upon palpation. And then I'm going to palpate the apical impulse, which is where the mitral is. And I'm assessing for any kind of pulsation here. It's a regular rhythm. It's brisk. It's about 2.5 centimeters wide. If the apical impulse is slightly displaced, it may be due to enlarged heart. If it's hyperkinetic, it could be from like exercise, young age, aortic regurgitation, aortic stenosis, or hyperthyroidism. Now we will go on to auscultating the heart sounds in the 5 pericardial areas, and I'm starting with my diaphragm. Okay. And then I'm going to listen to the sounds again, but using my bell this time. Okay, so upon auscultation, S1 and S2 is heard. No extra sounds of an S3 or S4 heard. No murmurs, no rubs, no gallops noted. And then at this point, I would assess the left lateral decubitus, but to save time on this assessment, I will not be doing that today. Auscultation. Next, we're going to be assessing for bruits in the arteries, and I'm going to start, he's supine, 30 degrees. I'm going to start in the carotid. So when I'm assessing this, I'm going to check one side first and then the next. I'll have you hold your breath for one side, give you a break, and then we'll do the other side, okay? I'm using the bell. Okay, hold your breath. Thank you. Okay, and breathe. Okay, and breathe. Thank you. No bruits heard in the carotid arteries. Then we'll be moving down to the femoral artery. Oh, I apologize, not femoral. We're going to be going to the abdominal aortic, which is in the middle of the xiphoid process and the umbilicus. And I'm using the bell again. No bruit noted in the aortic artery either. And then we'll be doing the renal arteries, which are a little bit lower, but midline to the aortic. Okay, no bruits noted in the renal arteries. Now we'll be moving down to the femoral arteries, which are in between the superior iliac spine and the pubis symphysis. Okay, and it's about here. It's a little hard to hear over the pants. Okay, and now check the right side. no bruits heard in the femoral arteries bilaterally. Okay. Next, we'll be moving on to assessing pulses. Pulses are graded on a scale from 0 to 3. 0 means that the pulse is absent. 1 means that it's a weak pulse. 2 is brisk, which is an expected finding, and 3 is a bounding pulse. First, I'm going to start with the radial pulses. If I can see your wrist, please. Thank you. And we typically assess the radial for a full minute, but today we're just going to be assessing the rhythm, which is regular, and amplitude, which is a 2+ here. Okay, thank you. We're going to move down to the femoral artery. Again, it's in between the superior iliac spine and the pubic symphysis. So it's right here. It's a little hard to feel over the clothes, but it's about a 1+ over the clothes bilaterally. Then if I have you bend your knees slightly, please, both knees, I'm going to be assessing the popliteal artery, which is behind the knee. I'm going to put my fingers here, back. Okay, and I'll do this side. And I got a 2+ on his popliteal. We'll move down to the posterior tibius, which is right behind the ankle, and these are great. They're both 2+. Then we'll go on to the anterior portion of the feet to the dorsalis pediis. This is good. 2+ as well on the dorsalis pediis pulses. Next, I'm going to be assessing upper and lower extremity edema. Pitting edema is a palpable swelling with an indentation that lasts 1 to 2 seconds, and it's graded on a score between 1 and 4+. Dependent edema is typically seen in lower extremities, and this is due to standing for prolonged periods of time or sitting for prolonged periods of time. Then you have the anasarcum edema, which is seen in patients with like liver and kidney failure. So I'll assess his upper extremities. Sorry, my hands are freezing. Skin is warm, dry, intact. No edema noted on his upper extremities. Then we're going to look at his lower extremities. Skin is warm, dry, and intact. No edema noted on his lower extremities either. And then can I please have you sit on this edge? Thank you. Okay, so we're in there. So I'm going to be assessing for skin turgor on the collarbone. So I'm just going to pinch it a little bit. And then, can you see that? Okay. No tinting noted. And then I'm going to look at your fingers, please. And he has a good cap refill, less than 2 seconds. His nails are smooth and flat. Hi, I'm here with Jessica. She's going to be helping me do my abdominal and neurologic assessments. To provide privacy to her, we're keeping on the shirt, but typically we would do this on bare skin. First, I will do inspection of the abdomen area. She has flat stomach, flat abdomen. It is symmetric. I don't see any bulging, so no masses or herniations visible. Her skin is appropriate for her ethnicity.
No lesions, no scars, no abnormalities noted. Now we'll move on to auscultation of the bowel sounds. I will start in the right lower quadrant. Okay, so she has normal active bowel sounds in all 4 quadrants. If you hear absent, if you don't hear bowel sounds, so absent, you're going to want to listen for 1 to 5 minutes. And for hypoactive bowel sounds, that's when you have less than 5 per minute. And hyperactive is when you have greater than 34 bowel sounds per minute. And that is the gurgling that we hear in this abdomen area. I'm going to listen over the spleen and the liver for friction rubs, which the sound of that over those areas can indicate liver carcinoma, inflammation, chlamydia, gonorrhea. And then you can also get a change in the sound with respirations. So first I'm going to look here over the spleen on the left side. And then over the liver on the right side, right upper quadrant. So no friction rubs noted on Jessica. Then I'm going to listen for a venous hum, which a venous hum is like a humming sound that is heard over the liver, epigastric, or umbilical region. And that can indicate that the patient has, I believe, liver cirrhosis. And then increased increased colloidal consolidation, that can mean liver cirrhosis. Okay, so I'm going to take a listen. Under the umbilicus, or at the umbilicus. No humming noted. Next, I'm going to do percussion of the abdomen. You want to hear a tympani over the abdomen area. You can also hear some dullness, which could mean a mass or collection of stool. So tympani was heard throughout the abdomen. Next, I'm going to check the liver. We're going to do the measurement. So I'll go on the other side. And then I'm going to start on the lower part of the abdomen and percuss and stop when I hear dullness. Okay, so here, can you hold your finger here for me? Awesome, marked it. And then I'm going to start on the upper chest and go down. Stopping when I hear the dullness. And now I'll measure in centimeters from the first point to this point, which is 8 centimeters, which is a normal finding. The normal size of the liver is 6 to 12 centimeters. And then next we will be doing the palpation of the abdomen. I'm going to start with the light palpation and then move on to deep. Please let me know if you have any pain or tenderness. Any pain or tenderness?
No.
Okay. And then deep palpation. Any pain or tenderness? No pain or tenderness noted. No mass is noted upon palpation. Now I'm going to assess for splenomegaly, and I'm going to palpate this right underneath the ribcage on the left side to assess the spleen. Deep palpation. Please let me know if there's any pain or tenderness. So no bulging or enlargement noted there. We'll go to the other side. Do the same thing for the liver, right under the rib cage, and I'm going to do some deep palpation. No bulging noted either. Any tenderness on that? Okay, no tenderness or pain. Then we're going to do some tests. We're going to test for appendicitis, and the first test is the Poisson test. So what that is, I'm going to have you just push up against my resistance. Okay. Any pain during that?
No.
Okay. And then we're going to do the obturator test. So I'm going to have bend your knee 90 degrees. We're going to go in. And then do you have any pain with that?
No.
Okay. So that would be a negative Poisson and obturator sign, which is normal. Then we'll be going and assessing rebound tenderness. So I'm going to go right in between the superior iliac spine and the umbilicus, right here. And I'm going to apply deep pressure and fast recoil. Did you have any pain on the other side?
No.
No. And she was relaxed. Try one more time. Ready? Any pain on the other side? Okay, so no pain there. Next, I will be going Rosenberg sign. So I'm going to go to the other side, and I'll be assessing the left lower quadrant. I'm going to do the same thing. Apply pressure, fast with a quick recoil. Any pain or tenderness? Okay, so that'd be a negative Rosing's sign. So no appendicitis would be warranted, or yes, and no pain. Next we'll be doing cholecystitis, which would be assessing the gallbladder. So go on this side again. Okay, so I have cholecystitis test. This is the Murphy sign. So I'm going to do the deep pressure again, and you'll take a big breath in and then out, okay? Once I apply deep pressure. Okay, ready? Deep breath in and out. Okay. Any pain or tenderness there? Okay, so that would be a negative Kernog sign. So next, we'll be moving on to the neurological. So I'm going to just take these out. I'm going to continue with her lying on the table first. So she is completely flat. I'm first going to put her chin to her chest. And then what I'm looking at is her lower extremities. I'm looking for any bend, any change in position. I don't see anything, so that's okay. And then the raising of the legs. So I'm going to bend her leg 90 degrees again, up. We're going to do a straight test. She's not that flexible, so any pain with that?
No.
Okay, good. Okay, so we'll put that down. And then the last one we'll do lying down is assessing for sensation. I have my dull and my sharp. So sharp, and dull. Okay? I'm gonna check your upper and lower extremities with your eyes closed. Please let me know sharp or dull.
Sharp. Dull. Sharp. Dull.
Okay.
Sharp. Dull. Sharp. Dull. Sharp. Dull.
Okay, So intact in the upper extremities. Now I'm going to be moving down to her lower extremities. Doing the same thing. Just let me know sharp or dull.
Dull. Sharp. Dull. Dull. Sharp. Dull. Sharp. Sharp. Dull. Dull. Sharp. Dull.
Okay. So she was able to accurately distinguish between sharp and dull. So her sensory function is intact. Now I'm going to have you stand up for me. Okay, and we're going to be looking at your gait, so your balance and coordination. I'm going to have you start at the beginning of the table and just walk across and then back. Oh, let me make sure they can see you. Okay, so walk across and then back. Very good. So her coordination and balance, she's steady. It's fluid, smooth. Her arms move equally and naturally as she walks. Next, is the Romberg's test. So what this one is you're going to close your eyes and you're just going to stand still for 1 minute. And I'm seeing if she loses, I'll go up a little bit. There we go. Loses her balance. So she's staying steady, not losing her balance. So we did this for a full minute. She would have a negative Romberg's test. Then we're going to do a rapid movement. So your thumb, you'll connect to your fingers. Rapidly. Okay, smooth, coordinated. She was able to do it fast. So that's intact as well. Rapid alteration movement. And then I believe I'll have you can sit down. You can sit down. And you're going to point to your nose and then, or touch your nose and then touch my finger, okay? And then touch my finger, and touch my finger, and touch my finger, touch my finger, touch my finger. Okay, so she was able to smoothly touch my finger accurately. No tremors noted of either of her, no tremors noted when she was connecting. And then we're going to assess heel to shin. So you're going to put your heel to your knee and glide it down your leg. Okay, and then we'll do the other leg. Excellent. So she had very smooth movements of her legs. And then we're going to have, hands up, and then you're going to hold them straight out. We're testing the pronator drift, and your eyes will be closed. And we'll do this for 10 seconds. And then we're seeing if there's any drift in her hands. She's able to keep them balanced and at the same level. Okay, you're good. Thank you. And then we'll do discrimination sensation. So you'll have your palms up again, and I'm going to put objects in your hands. Just try to tell me what they are with your eyes closed, please. Okay.
Paper clip.
Okay, yeah. And then
Coin.
okay. So she was accurately able to describe the two objects that I placed in her hand. So her sensation was intact. Oh, her stereognosis was intact. And then we'll be checking for the graphiothesia. And that one, I'm going to palms up again. And with your eyes closed, I'm going to write a letter or a number in your hand. Just try to tell me which ones they are, okay?
B.
Okay.
8.
Okay, so you can open up. She was able to accurately distinguish between letters and numbers with her eyes closed. So that was also intact. And that will conclude my assessment. Thank you so much for your assistance.